Provoking. We're now going to have a look at the introduction of equipment to facilities that enhances the quality of care for the residents, and how to develop and implement a person-centered care model in a residential care facility. And to discuss this, I introduce Ilse Haasbroek and Dr. Henny Loubser. And Dr. Henny Loubser said he's going to tell us more about himself as he introduces himself. Thank you.
So, a brief history. I met Ilse probably only 3 months ago, and I'm quite passionate about person-centered care, but Ilse passed me quite dramatically when she wanted to show me her holistic care plan for person-centered care, and disappeared off to the printer, came back with a whole layout of one of the most very interesting assessments that I've ever seen, and in fact we're going to share it with you later. So I thought this would be a great person to have join us. Ilse, thank you. We appreciate you being here. And then I got introduced to Henny from another partner of ours in the Western Cape, and she told me on 2 occasions, I really need to speak with Dr. Henny. And we had a discussion, and I was very encouraged to hear more about supportive care rather than traditional nursing care. And if we look at the problems that we faced with our elders, loneliness, boredom, and helplessness, these are the 3 elements that most elders face, what they fear most. And quickly, just if we look at the opposite of helplessness, what is it? It's functional, it's mobility. And then if we look at the opposite of boredom and loneliness, what is that? It's purpose. And this is what I love about your plan, your assessment. So without me saying too much more, I look forward to this conversation. It's going to be very interesting, and we appreciate you joining us today.
Thank you, Steve.
Thank you. Well, I just want to say, Famida of TAFTA, the presentation we just looked at now, it is very much in line in our thoughts also, and we would like to just add on to what she's saying now. Fantastic. I think this is going to follow up from what she's trying to say. If you want to know who I am, I'm Henny Loubser. I'm a medical doctor. Started my gerontological career in Port Shepstone on the south coast of Natal, so I'm very familiar with TAFTA those years. And that I did my postgraduate studies in gerontology, master's and PhD in nursing, gerontological nursing, and occupational therapy. Okay. Good. So we talk about, I think if we want to put everything together that has been said about gerontological care, we should go back to Shakespeare in 1593, where he said, the meaning of life is to find your gift. And the purpose of life is to give it away. And that's what gerontological care is all about. It is about allowing the person that's in your care to find their gift, their talent, and then what you then do is you allow them to share it with others. And that's what it's all about. So it speaks really to the ICF framework. The ICF framework is the framework of the World Health Organization. And I would just like quickly run through that for you. Now, if you look at what a health condition is, now your health condition can be elderly person, right? A frail person, a demented person, or a person in assisted living. What is their dependencies and their needs lies amongst body functions and structures, their clinical illness, their activities, their abilities, their participation, and their environmental factors and their personal factors. Now, what we in healthcare or in gerontological care must find, and you can go to the next slide, is the sweet spot amongst that. That is gerontological care. We cannot focus. You can go back again, please, if you don't mind. We cannot function. We cannot focus on body functions and structures like what we're doing at the moment. And we ignore all the rest. Now, activities, you can look at your activities of daily living: eating, grooming, bathing, dressing, toileting, washing, walking, comprehension, expression, social action, problem solving, memory. That is that. But they are all interdependent on one another. There's a fine balance. Now, I would like you, like Ilse, to just talk about participation, environmental factors, and personal factors.
Thank you, Ine. Yes. When Ine and me start speaking and talking, it really carries on forevermore, so we can carry on the whole day. So we really have to limit ourselves here. And when it comes to participation, it was like Tim said, the whole team has got to be part of that participation. Because from the garden worker to the house manager has got interaction with the resident. And everybody's got to participate in sharing a common vision, in creating an environment in where the resident can flourish with dignity. At the end, it's about dignity. And creating an environment is not only just about bricks and mortar, but it's also about how do I enable my resident more to still be functional, to still be able to do things for myself, because that gives me dignity. The other day, I've heard a very nice expression that said, dignity equals care in action. Yes. And that is really what dignity is about, is care in action. So, and quite often we find in our facilities that the way we manage, the way we nurse, the way we carry out some certain procedures, we are disabling the resident more than enabling the resident. We are just taking over, doing everything for themselves. That's not about creating an environment where I can flourish with dignity. And what is needed in my environment is not going to be the same what is needed in your environment.
No.
Because each of us has got personal factors that impacts on my environment, on my situation, on my socialization. With us, we make use of a tool which we call the Know Me Better tool. So for you to take good care of me, to understand my needs, you need to know who I am.
Yep.
You need to know what is important to me. What do I like? What do I dislike? Because only then you will be able to understand who am I and care for me in a way which is suited for me, not for you or for the staff or for the rules or the regulations to it.
Do we have a copy of your
Yes, it's coming
Okay,
on
lovely.
onto the...
You can carry to the next slide. I think, this is the current elder care dilemma. I think Ilse can talk to you about, from a nursing perspective, what is the current dilemma that we have. And I'm not saying the forward-thinking facilities. I'm talking about the current dilemma of 90% of the facilities.
In a lot of our facilities, we find that the focus is 95% on curative. It's on the clinical observations, the diagnosis that we see. So the person that is starting to lose its identity. It's becoming a body-in-bed management. The hip replacement in room 7, the dementia in ward F, or whatever. So it is not home to them. We give ourselves out as a mini hospital, and that is what people and families are expecting of us. So in a certain extent, we are the ones creating this learned helplessness syndrome. We are the ones creating the storm, and then we cry when we don't have enough hands to nurse all these people. Because we take on a one-size-fits-all approach. Everybody's got to fit into this time slots of bathing, into this time slots of eating, into this time slots of having tea. Not having a choice, my own choice. When do I want to be bathed or showered or dressed or get up out of bed? And that increases the burden of unnecessary care given. I can quickly tell you a short story here about a resident which I've had, and I mean the family, when I saw the name ringing on my cell phone, I don't want to even answer the phone because I just knew what the conversation is going to be. At the end, I went to the facility, sat down with the seniors, and had a discussion about the resident and the complaints that we had to adhere with. She's losing weight, she's forever falling. Yeah, but the staff, but she's not eating properly, she's fussy about her food, she's using too much pain medication, and she insists on going to the toilet. So we're taking away her walking frame and putting the commode in the room so she doesn't walk. What are we doing? We are disabling the resident. In the end, I said, well, give all the information, give me a Know Me Better. And on the Know Me Better, I found her biggest dream at the age of 87 is to fly in a helicopter. And I said to them, did you know that that is the biggest dream? No, we don't. Well, what does this have to do with the problem? I said, well, what do you think will happen if we say to her, we put up a big picture of a helicopter in a room, and we say to the resident, when you start working with us on your dietary program, and you can help us so that we increase your weight up to 60 kilograms, and you can walk 100 meters, we will make sure you get to fly in a helicopter. Guess what? 4 months later, they walked into my office and they said to me, can we show you something? And they showed me the photos where she went on a helicopter ride.
Wow.
That is person-centered care.
Great story.
Taking a problem and turning it around into
A solution.
functionality, purpose, mobility, and making her dreams come true.
Fantastic.
At the age of 87.
It's a great
And
story.
that is what person-centered care is about.
Yeah, there is no one size fit all.
Mm.
If the staff cannot understand that each person is a different individual with different needs, then we're not going to get anywhere. Next one, please.
So that way we keep them out of hospital and keeping our cost in control and making the burden on the nursing staff less.
Well, this is, of course, the problem that we have. And I would like to bring this into the continuum of Farida. Famida. What we're actually doing is we're actually breeding frailty. And hospitals focus solely, if you look at the care models in hospitals, and we're talking care across the continuum of care, they focus on stabilizing organs and systems. If you've got a heart attack, you go to hospital, they stabilize you, right? After that, you must get out of the hospital. Because if you keep on lying in hospital, you will start developing deconditioning syndrome. And this is a huge problem. And deconditioning syndrome, the medical word for it is sarcopenia, which means wasting of muscles. And then organs and systems collapse as a result, again, of sarcopenia. If sarcopenia doesn't go, then if we can prevent sarcopenia, then the organs and systems will work. So medical scheme funding becomes out of control now, and the elder person becomes very poor. The elder outcomes becomes very poor. The question is, what is outcomes? What is outcomes? We can just say no mobility, no dignity, no wellness. So if we can just get to the next slide, we've got to go through these things. So our mission is then to change our mission, keep our elderly out of hospitals. They are at high risk when going into hospitals, very high risk, because their organs and systems falling apart. If they get a rhythm disturbance, they get a pacemaker. If they get a pacemaker, then they have a bed sore. Then they have an electrolyte imbalance and things like that. So we've got to keep them out of the hospital. Next one. What we at I'm the owner and CEO of the South African Database for Functional Medicine, which works on elderly people. It is, we are measuring routinely on a daily basis, like what you measure blood pressure, pulse, and temperature, we measure function. What we measure here, this one here, this instrument that we have done is on the clinical side of the patient. I'm not going to go into detail, but the more the score goes to 2s and 1s, they would need Arjo. Go further to the next one. This is self-care. So those are all the activities of daily living. The yellow, if the patient scores or a person scores in the yellow, they will need most probably consult Arjo for mobility, help with mobility, right? And that is what we call restorative care. So we don't like the word care very much, because care can assume that we patronize you and we do everything for you. But we would like to have the term restorative care, which means we will give you the helicopter ride, right? Go for the helicopter ride. And that is independent living scale then, which is the gamma. And we do all of them together. And this is done by the carers, please let you know. The carers are trained and they do it daily, and they do the scores daily. So what you can see in that dashboard report the 3 things. How does the functions of body, organs, and system affect independent living, and does it affect the assisted living? And so you can see all of that. It is clearly seen. Now, Ilse, you come with your program.
Through my experience, what I found was we do all of this analysis. We do all of the risk reports on all different functions, on bed sore risk, on fall risk, on incontinence risk, etc., etc. But the problem is, how do we interpret this information? We gather all of this information, but how do we interpret this to an easy, understanding care plan which is fit for Mrs. Viljoen? What do I do with all this information from my evaluations and my Know Me Better and everything? We need to create goals. We need to create a purpose for that resident. And we're not just a body in a bed. We don't consist only of a body. And unfortunately, the science of nursing only focuses on the physical side. Unfortunately, that is all that nurses are trained in. So if I've dressed you, if I've given you medication, if I've washed you, if I've combed your hair, brushed your teeth, washed your ears, job well done, I'm a very good nurse. But what about the emotional and the spiritual and the intellectual care of the resident? That makes me a whole person. So I have to interpret all of this information into a very easy understanding plan that everybody is on the same page and of which the resident and the family is part of. So on physical, you would quickly see all the different domains over there and what would be the purpose. Let's say, for example, on dressing. The resident can dress him or herself on the top part, but need assistance on the bottom part. So I will write it in there. On the emotional side, do I know their dreams? Do I know their fears? Do I know difficult situations? Do I know what brings them joy? Our domains of well-being. And all of our domains of well-being is built into this one-pager, which the most basic ground care worker will be able to understand and support the resident in. And everybody understands the purpose of their day and what needs to be done in the day. I want to close off with an elder's prayer, which says, as I function, so shall I live. But cometh the day I outlive my functions. Please, will you uphold my dignity? And then we know we need all kinds of support, equipment, and all of those things to uphold my dignity.
Brilliant.
Yes, I think Ilse as a nurse and me as a doctor works as a team together, and there is great consensus amongst Ilse and myself that our problem in long-term care, or not problem in gerontology, our main problem does not lie with carers. Will you tell them where the problem lies?
Yeah, I think the carers are the least of our problems. They are the ones who's very keen and very eager to make the mind shift into working closely to the resident, because
Yes.
they are the ones who have to perform the actions. But a lot of our nursing procedures is actually very undignifying in the way that they are performed, being bed bathed, being dressed. And there's a difference in the way that you're doing, whether it's just the job or whether it's being done with dignity. And with having just a focus on curative care, we become this mini hospital. And our frail care or our long-term facilities think they are not able to function without the medical model. But really to render dignity to the resident, to give them choices, to bringing the domains of well-being, we need a multidisciplinary team that consists of a nursing practitioner, which would be the clinical consultant, to take care of the medication control, the infection control, the wound control, the medical side of things, the vital signs, know when I have signs and symptoms of low blood sugar or of hypertension or whatever it may be. But I also need my physiotherapist to help me to bring mobility, to make the residents stronger, to build muscle. And with mobility comes functionality, where my OT comes in, that falls in the gap in intellectual stimulation and also bring back functionality, bringing them out of that loneliness, bringing them out of that helplessness. And in the end, let them socialize again, let them be who they are and integrate with the rest of what is happening in the facility, regardless of my disease, regardless whether I'm living with dementia. I am just me.
Elder care is not medical care. It is the result of a lack of restorative care. If you would restore right from the beginning an elderly person, then there should be minimal need for clinical care.
And I think in Eden it also says medicine should never be the master of care.
No, exactly.
Yeah, well said.
Yeah. And if we can measure it, we can manage it.
Yeah.
The problem is we can't measure it. We can measure it. We've shown you now. And it can be done routinely, and it can be done daily, and it can be fit on the continuum of care, and you can take these measurements right out of the acute hospitals where it's used already. It is used in rehabilitation hospitals already. We should move this measurements now routinely into the frail care or the elderly care or the long-term care people.
So, Henny, I hear exactly what you're saying, and I agree with the fact that functionality relates directly to safety and dignity.
Yes.
How would you...
And health.
Yeah, true. Well-being, too.
Yes.
The mobility gallery tool which we have,
Yes.
would you consider that a valuable tool to be used in facilities with this approach of measuring functionality?
The measuring of functionality is to decide how quick and how fast can we introduce all these tools that people can't manage without anymore. It should red flag individual patients that these patients need these mobility tools of Arjo. This is what we see, and we can even benchmark it on the scores that this patient now needs this tool. Yeah, because if two people handle a patient, the threat of hurting the patient comes up very quickly. And if you score 1 or a 2 on one of those tools, two people are actually having to do the job. Yeah.
Well, an interesting discussion, perfectly fitted for the topic of today, which is, exploring the mental and physical positive outcomes associated with person-centered care. So we really appreciate you coming into studio, Henny, all the way from the Western Cape. Ilse, thank you. Your passion is contagious and it bubbles over. A great story about the helicopter ride. And it brings me back to the importance of purpose. How do we overcome the loneliness and boredom? We need a purpose. It's like running a marathon. You have to have a goal. And that's to get you to do the training. But also, without the purpose, you wouldn't have the motivation to do what it is that you need to do to be functional.
Yeah.
There's a saying, use it or lose it. And this
Absolutely.
is so true. The atrophy that you spoke about earlier, it's a very real thing.
I can remember we received this resident once, and he was only 68 years old, also with very bad brain damage due to Korsakoff syndrome. And he came in as a big baby, and he was completely bedridden. He couldn't walk, he couldn't talk. He was on incontinence wear. He was only drinking fluids. He couldn't even eat normal food. And I said to the care workers, he's just young to give up on him. And I asked his wife for a chair to sit, a proper chair for him to sit in, dye clothes so that he can be dressed into day and night. Whether he knows it or not doesn't matter. It is for his dignity, because he's going to receive visitors. And we started working with him in small steps. Every day, sitting up a little bit longer, then later standing up, then later starting to walk small steps. And 3 months later, let's call him Ben. 3 months later, Ben was walking, he was talking, he was dressing himself, he was shaving himself, he was brushing his own teeth, he went to the toilet by himself, he ate normal food. He talked a whole lot of nonsense, but who cared? We gave life back to him. And he still lived with his new life for quite a number of years after that, to the wide surprise of his family. That they couldn't believe what had happened. But I always said to the carers, if we have nursed him the way that he came in, he would have passed away 3 months after that. Because quite often we are so busy nursing the procedures and the policies and the regulations that we forget about the person who the care is about.
Very well said.
I'm looking forward to that facility we were talking about just now that is managed by an occupational therapist. I'm really looking forward to that.
Lovely. Thank you both. It's been fantastic having you. Good
Thank you very much.
discussion.
Thanks, Steve.
Thank you very
we
much.
appreciate it very much.
Thanks.
Bye.